Hello, this is Dr. Kostelnik with Rooted Behavioral Education. I'm a clinical health psychologist and fellow vestibular patient. And today we're covering a very important topic can be a big piece of vestibular recovery, and that's vestibular rehabilitation therapy, or VRT. And we have a very special guest today, Dr. Adriana Delgado. She is a doctor of physical therapy and a clinic director at an outpatient clinic that specializes in vestibular and neurological conditions. She has 7 years of experience treating dizziness and balance issues. In addition to that, she has competency-based certifications in treating vestibular issues. She's passionate about working with this population. She likes to collaborate with other healthcare providers to return patients to their prior level of functioning. She's the go-to vestibular PT referral for one of the top vestibular doctors in Los Angeles, and she's currently seeing patients via telehealth in California. So if you're interested, I'll link the clinic information below. So welcome to Dr. Adriana Delgado.
Hi, thank you so much for having me here.
Sure. So let's start off kind of with the basics and talking about what is vestibular rehabilitation therapy, or VRT.
Yeah, so the basic definition of that is that it is a specialized form of therapy that's usually provided by trained physical therapists or occupational therapists for inner ear related disorders that are causing dizziness or imbalance. The rehab part of that is that we base our treatments through therapeutic exercises or specific techniques that are to target patient-specific goals or symptoms or diagnosis.
Okay. So you gave kind of the overview. So what does that typically look like in the clinic? So what is like the everyday experience of VRT?
Yeah, so it's to get a better understanding of that. I mean, it's going to look different for every single person walking in. But, to understand what the vestibular system does is that it is important for maintaining our balance, maintaining our sense of orientation to space, and being able to maintain a clear visual system when we're moving our heads primarily. So you have other two systems for balance and sense of orientation. That's our visual system, being able to know how things are around us relative to the world and sense movement around us. And also our somatosensory system. This is the input from our trunk, our muscles and tendons, being able to know where we are in space relative to the ground. So with that little background stated, in order for us to treat vestibular disorders, if it's coming from the inner ear, like if there's a weakness on one side, then we tend to restore and strengthen that signal. This can be through head turns, eyes closed, standing on different surfaces, walking activities. If patients are having more difficulty processing all those three systems, this could be done through usually starting by getting more posture retraining, getting more like core stability, and getting to maybe even working on the neck a little bit so patients are using that system a little bit better. The other part of the VRT is VPPV treatment, doing specific maneuvers for patients that are having dizziness from the crystals being out of place. And then just overall conditioning, endurance training. Patients are not as active as they used to be because they're dizzy. So I want patients to get back to their activity level before all of this happened.
Oh, good. Well, speaking of posture, it's reminded me that I can work on my posture. And I didn't mention in the beginning that working with Adriana Delgado, she was my personal vestibular physical therapist, and she's just awesome. So I'm so excited to be able to have her here to share her wisdom.
Yes, I'm analyzing your posture.
I know. I was thinking, oh my goodness, I'm really hunched over. Just so everyone knows, we did work on posture in VRT. I just need to keep it up. So talk a little bit about, if you would, how you evaluate vestibular patients and how does that inform your treatment plan?
We usually start with a patient interview. So getting a comprehensive review of the patient's medical history, being able to also get an understanding of the patient's symptoms, when their symptoms started, how that has evolved over time, how they're describing their symptoms. Can they use a different word besides dizzy to explain what's going on, which is sometimes really hard to do in this population. And then just being able to know, are there any symptoms, any activities that make their symptoms better, make their symptoms worse. And that usually takes about 20 or 30 minutes of the evaluation process. The rest of it is looking at testing, starting with how the eyes are working together, how they're moving, because our eyes give us a lot of information about what's going on, not only in their symptoms, but also in relation to the vestibular system. Looking at how the patient is walking, the quality of their walking, and any abnormalities in the walking that is specifically affected by the inner ear system. Looking at the balance, looking at strength, looking at a reflex between the eyes and the inner ear, and then also looking at neck range, any restrictions in the muscles around the neck, and then looking at posture.
Okay. So you had mentioned BPPV before, and so I'm assuming that's a pretty common one that you see. So what are the diagnoses that you're seeing most often come into your clinic?
On a regular basis, because they are the most common, and I just get the most referral from doctors for this, are persistent postural perceptual dizziness, so 3PD, vestibular migraines, and then also our acute or chronic vestibular neuritis, labyrinthitis, the inner ear infections. We do treat other diagnoses. They're just not as common. Those are like Meniere's, acoustic neuroma, superior semicircular canal dehiscence, and malleate debarkment.
Okay. So along those lines, so which diagnoses are there certain diagnoses that tend to see the most gains with therapy?
Yes, I mean, just in general, there's a lot of evidence to support vestibular rehab and successfully treating and reducing the dizziness in patients. The ones that see the greatest benefit once they are medically stable, there's some conditions that have to be medically stable first to get a better benefit from therapy. Those are like even semicircular, superior semicircular canal dehiscence, Meniere's, migraines. Once that is not a concern, any of the vestibular diagnoses that we talked about, that we mentioned, can benefit from therapy to reduce the symptoms, to return to some kind of activity level. I mean, it's just, I think it just benefits any of those patients.
Great. Well, that's, I think, great news for everyone, and hopefully can build some hope if those of you are listening and wondering, what might be the next step in your treatment plan. So when do you think is a good time for someone to start VRT? And you had mentioned that certain diagnoses you might want to be medically stable first.
Right.
So when is a good time to start, and then what might they expect? You mentioned doing the evaluation. So what might they expect coming in to see you, and then in future appointments?
Yeah, that's such a good question. I mean, I think patients can always come into therapy for an evaluation. That doesn't always mean that they're going to have treatment, but after we do our evaluation, if a patient doesn't have a diagnosis, then because we can't diagnose patients as therapists, we'll refer them to a specific doctor that specializes in dizziness. And if a patient is coming in for the evaluation and they do have a diagnosis, we can start treatment immediately. And that usually is, we start patients with once a week or twice a week, depending on what they need.
Okay.
For our clinic specifically too, actually our sessions are 1 hour, and they're always one-on-one with the therapist.
Okay. And then what is the typical length of time, like both in terms of how many months that your therapy takes, and how much do you expect from patients in terms of what they're going to do at home?
Yeah. So overall, I mean, there's a lot of commitment in the very beginning. So even with therapy, as I mentioned, we can start with once or twice a week for patients. As they start to get better, we typically reduce that frequency to once a week, and then to once a month. For the more chronic dizzy patients, I tend to see them every couple of months or every few months just to keep track of their progress, maybe modify or update some of their home exercise program. And you mentioned how much time they have to do that at home. And the very beginning, daily,
Mhm.
daily, daily, daily. After that, there is, patients get better. You don't need to do it as often, but there is still some level of commitment. A lot of commitment actually early in the process as you're starting to recover from all of this.
Mhm. So, in your clinical experience, are there certain factors that predict people doing really well in VRT,
Mhm.
and then certain things that might make it more difficult for them to progress?
Yeah, I mean, the best patient outcome, it does depend on the diagnosis, but and once things are medically stable, but you know, being able to follow your doctor's recommendations, your ENT and neurologist is kind of the big thing. Committing to therapy, that means you show up to therapy, you do all the exercises, and then most importantly, your lifestyle modifications, your stress, your sleep, your diet, exercise, which we all need to do anyway, but most importantly for vestibular disorders. And the patients that don't tend to do as well or have a little bit more difficulty improving, if there are no medical concerns, right? They have no other comorbidities that are limiting their progression, then there's a huge psychosocial factor and social support. So patients don't have that or don't have the resources available to help with that, then it makes it a lot harder. And I think you do a great job in your course talking about the research behind all the psychosocial factors and social support, that how that affects the vestibular disorders and how that affects patient symptoms. And I honestly think you can have vestibular therapy without addressing all the other factors
Mhm.
themselves.
Yeah, and I agree. And just kind of from my patient perspective, going through it, and then as a psychologist, I was like, wow, there's so much I could do to kind of help educate people about this. And it's hard because the physician appointments and then even PT, like they're relatively short and there's just not time to address everything. And
Yeah.
then besides that, there's not very many resources for the behavioral health aspect, which is what kind of inspired me to create the course that I did.
Yeah.
Um, so if someone were looking for a vestibular physical therapist, what should they look for? Are there certain qualifications that they would want in a physical therapist?
Uh, Qualifications, I mean, certainly there's no like specific board certification. I think patients they can just go to the Vestibular Disorders Association, the website, the vestibular.org, and there they can find in the directory as any trained therapists around their area. Qualifications, it just depends. Like, do you feel comfortable with your patient? I mean, with your therapist, do you feel like you can communicate really well with the therapist? I mean, and you'll know that from the first session, because it's really important that you do feel like you're in good hands.
Mm-hmm. Mm-hmm. Okay. Well, I think that we got covered, like laid a really good foundation for anyone that might be interested in VRT and wanted more information. So I just wanted to thank Dr. Adriana Delgado so much for her time today. Again, I'm Dr. Kostelnik with Rooted Behavioral Education. You can find me on Instagram, Facebook, at my website, rootedbehavioraleducation.com, and we'll see you next time.